Hi everyone. I'm going to start doing the A&P review for health assessment for next semester. So if you have any questions, if you could please just save them for the end of the presentations. There's like 6 or 7 chapters that we're going to go through, and then after each chapter, I have review questions for us to do. So if I'm asking you a question, please feel free. If you want to type in the chat box, or if you want to turn on your microphone and ask any questions, you can do that. But while I'm presenting, if you could please turn off your microphones, and then after the end of the chapter, we'll do the questions and you can turn on your microphones. Okay, so I'll go ahead and get started. And if anyone has any questions before we start, if you want to type them in or just put on your microphone and talk now before I get started, that's fine. I'll give you a couple minutes. Can everyone see my screen? I just want to make sure that before I start. Anyone can answer yes or no if they can see my screen. Okay, good. And can you guys hear me okay? Okay. All right, so the first chapter that we're going to go over is skin, hair, and nails. I just want to leave this on the side so I can see if anyone has any questions if you're typing. Okay. Does that look good to everybody like that? Okay, good. So the structure of the skin. Think of the skin as the body's largest organ system. In adults, it has a surface area of up to 20 square feet, and it's the century that guards the body. Now, the skin has 2 layers. The first layer is the epidermis, and it's the outer, highly differentiated layer. It's made of basal cells, which form new skin cells, and the outer layer has horny cell layer made of dead keratinized cells. The dermis is the inner layer. So 2 layers of the skin. The outer is the dermis, the outer is the epidermis, inner is the dermis. And the dermis is made of connective tissue or collagen and elastic tissue. And beneath these 2 layers is a subcutaneous layer of adipose tissue. And the adipose tissue stores energy for fat for energy. It provides insulation for temperature, and it controls and aids in protection. And as you can see here, this is the epidermis, which is the outer layer, and the dermis, which is the inner layer. And the subcutaneous tissue lays beneath the epidermis and the dermis. Now, here are the sebaceous glands. The sebaceous glands secrete sebum, which lubricates the surface of the skin. And the sebum is stimulated by androgens. And androgens are male sex hormones like testosterone. Primarily, the sebaceous glands are located on the face, chest, and back. The eccrine glands are known as sweat glands, and they help the body to cool down. Now, the eccrine glands are mostly located on the hands and on the feet. The apocrine glands are here, and they do not empty onto the skin surface, but onto hair follicles. So as you can see here, this is the hair follicle, and the apocrine sweat gland is attached to it. They're mostly located in the genital region. The erectile pilae muscle, which is over here, it's also attached to the hair follicle. It's a tiny muscle that attaches to the base of the hair follicle and causes the hair to stand up straight. So erectile pilae muscles are commonly known to cause goosebumps. As nurses, it's important for us to understand the different layers of the skin and structures of the skin because of our role in medication administration. Certain medications can be given intradermally or subcutaneously, which means that they go into this fatty layer of tissue that's underneath the dermis. Does anyone know any medications that are given subcutaneously? Can anybody think of any? Insulin, right? Insulin is an injection that we give commonly into the subcutaneous tissue. And when we give these subcutaneous injections, we're making sure that we pinch the skin, and we're giving the injections at a 90-degree angle so that it can reach deep into that subcutaneous tissue. Okay, so now we're going to move on to skin color. Skin color is derived from 3 sources: from melanin, which is brown pigment, from carotene, which is a yellow-orange pigment, and red-purple tones are from the underlying vascular bed. All individuals have varying amounts, so they all have varying amounts of melanin, carotene, and red-purple tones. Also, our skin color is modified by the thickness of the skin and by the presence of edema. And edema is swelling in the tissues. Hair, sebaceous glands, and sweat glands are structures formed by the tubular invagination of the epidermis down into the underlying dermis. Sweat glands are important for fluid balance and for thermoregulation. So we kind of talked about the differences between the eccrine glands and the apocrine glands already. But just to repeat, eccrine glands are known as sweat glands, and they help the body to cool down. They're mostly located on the hands and feet, whereas apocrine glands do not empty onto the skin surface, but they are attached to hair follicles. And the difference between the two is their location. Apocrine glands are mostly located in the genital region. Hair are threads of keratin, and forming hair is the hair shaft and the bulb matrix. There's different types of hair. There's vellus and terminal, and the hair follicle is the sickle with active and resting phases. The sebaceous glands are the sebum glands, which are secreted with lipid substances through the hair follicles. They lubricate the skin and form emulsion. The sweat glands are the eccrine glands and the apocrine glands. The apocrine glands secrete a watery substance, whereas the apocrine glands secrete a milky substance, and they open onto hair follicles. Nails are hard plates of keratin on the dorsal edges of fingers and toes. So this picture is just showing the structure of the nail. The nail plate is the hard surface of the nail. There's the posterior nail fold, cuticles, the lateral nail fold, which is here on the side, and then beneath the nail plate is the nail matrix. Now we're going to talk about the function of the skin. The skin is waterproof, it's protective, and it's adaptive. It protects us from the environment, it protects us from penetration, it allows us to perceive things, it aids in temperature regulation, in communication, in wound repair, in absorption and excretion, and importantly, it helps us to produce vitamin D when we're exposed to the sun. Okay, so that's it. I'm going to go over after each chapter that we review. I have a PowerPoint here, so we can go through and do the questions for skin and for hair. So is this true or false? The skin is considered an organ. True or false? What do you guys think? That's true, right? The skin is an organ. It's actually the largest organ in our body. All right, good. So let's do the next one. The skin is composed of how many layers? 1, 2, 3, or 4? What do you guys think? 2, right? And what are those layers? Do you know, Nicole? Dermis and epidermis. The epidermis is on top, the dermis is below. And what's below the epidermis and the dermis? The fatty layer beneath those two. What do you guys think that's called? The subcutaneous layer, right? That's the fatty tissue that's beneath the epidermis and dermis. All right, so let's go on to the next one. Which layer is not a part of the integumentary system? The hypodermis, dermis, or epidermis? Or are all of these a part of the system? What do you guys think is the answer? Which layer is not a part of the integumentary system? You guys can type in, or if you want to talk, that's fine too. Or if you don't know, just say I don't know, or you're not sure. example. Remember the epidermis and the dermis are the layers. The hypodermis is actually not a part of the integumentary system. Okay, so the answer would be the first one, hypodermis. Does that make sense? Okay, good. So this is the last question that I have for this chapter, and then we'll move on to the next one. What area of the skin structure is responsible for the goosebump formation of the skin? Erector pili, yes, correct, Nicole. That's it. Okay, was that helpful doing these questions? Okay, so let's go on to the next chapter now. The next chapter that we're going to do, and just so you know, you guys have access to this module. I'll share it with you at the end, and there's videos that you can watch along with these PDF slides. Okay? So now we're going to do head, neck, and regional lymph nodes. Okay, so the head. The head contains the skull, and the skull is a rigid box that protects the brain. It includes the bones of the cranium and the face, and it is supported by the cervical vertebrae. The cranial bones include frontal, parietal, occipital, and temporal bones. And sutures are the adjacent cranial bones that mesh at the sutures. There's coronal, sagittal, and lambdoid. The head is made of 14 facial bones that articulate at sutures. Facial expressions are formed by facial muscles, which are mediated by cranial nerve 7, the facial nerve. 2 pairs of salivary glands are accessible to examination on the face, and those are the parotid glands, which are in the cheeks over the mandible, anterior to and below the ear, and these are the largest salivary glands. However, they are not normally palpable. The submandibular glands are beneath the mandible at the angle of the jaw. The third pair of sublingual glands lie in the mouth and floor of the mouth. The temporal artery lies superior to the temporalis muscle, and pulsation is palpable anterior to the ear. Okay, so this picture is just showing the different bony structures of the head. The frontal bone lies in the front, parietal bone is on the side, occipital bone is in the back, and the temporal bone is a little bit more lateral. The maxilla is the top structure of the jaw, and then the mandible is the lower structure here. And this shows the cervical spine. So C stands for cervical, and then 1 stands for the first bone of the cervical spine. So when you see C1, you know that's the first bone of the cervical spine. So next thing that we're going to go over is the neck. The neck is delimited by the base of the skull and the inferior border of the mandible above. Think of the neck as the conduit of many structures. Inside of the neck are vessels, muscles, nerves, lymphatics, and the viscera of respiratory and digestive systems. The internal carotid, which is located inside of the neck, branches off of the common carotid and runs inward and upward to supply the brain. The external carotid supplies the face, salivary glands, and superficial temporal artery. The neck muscles. The major neck muscles include the sternomastoid and trapezius, and the sternomastoid and trapezius are innervated by cranial nerve 11. The sternomastoid muscle allows the head to rotate and flex, and it divides on each side of the neck into 2 triangles, anterior and posterior triangles. The 2 trapezius muscles move the shoulders and extend and turn the head. The thyroid is a gland which is also located in the neck. It's important to know. because patients might have conditions such as hypothyroidism and hyperthyroidism. So it's important to know and understand the location and the function of the thyroid. The thyroid, what it is an endocrine gland that straddles the trachea in the middle of the neck. It synthesizes and secretes the thyroid hormones, and the thyroid hormones are thyroxine or T4 and triiodothyronine, which is T3. And these hormones are mainly responsible for cellular metabolism. It has two lobes, and the two lobes are connected in the middle by a thin isthmus, and above that by the cricoid cartilage or the upper tracheal ring. The thyroid cartilage is a small, palpable notch in the upper edge, also known as the Adam's apple in males. The cricoid cartilage or upper tracheal ring, and the isthmus of the thyroid gland. Okay, so this picture is showing all the muscles that we talked about. So the sternoid mastoid muscle, as you can see here, and then the thyroid glands. The thyroid gland is in the middle here, and then it's talking about the different cartilages which connect to the thyroid glands. The cricoid cartilage is here, the thyroid cartilage, and then the thyroid bone. And these all connect to the clavicle. The sternoid mastoid muscle here, and this is the clavicle. Now, the lymphatic system is a major part of our immune system, and also it's important in our circulatory system. The lymphatic system helps us to rid the body of toxins and waste, and it does this through lymph. And lymph is a clear, colorless fluid that contains white blood cells or lymphocytes to fight infection. And the lymph actually empties into the venous system. The lymphatic vessels, unlike the venous system, however, do not contain a pump like the heart to control the flow of the lymph. So it relies on inner valves and contractions of the surrounding muscles that propel the lymph in one direction. Okay? So again, it's a major part of the immune system. It detects and eliminates foreign substances from the body, and it has a rich supply of lymph nodes. The greatest supply of lymph nodes are in the head and in the neck. The lymphatic drainage helps to prevent us from potentially harmful substances from entering into the circulation. It's important for us to be familiar with the direction and the drainage patterns of these lymph, and we'll go over that in a couple of slides. There's a picture that goes over that. Okay, here, so this is the drainage pattern. See how the arrows are showing that it's going from the center to the outside, and the lymph nodes kind of form a ring around the head. It's important for us to recognize the patterns of these, the flow of the lymphatic system. So remember that it flows from the center of the face outwards. And as it goes down here, it will actually drain into the subclavian and internal jugular vein. So this slide is talking about the different lymph nodes. So the preauricular is in front of the ear. So as you see here, this is preauricular. The posterior auricular is behind the ear or superficial to the mastoid process. The occipital lymph node is at the base of the skull. The submental lymph node is midline behind the tip of the mandible, and the submandibular lymph node is halfway between the angle and tip of the mandible. Okay, so let's look at this picture so we can identify these different ones. The occipital here at the base of the skull, preauricular in front of the ear, posterior auricular behind the ear, submandibular beneath the mandible, right? This is the mandibular bone. So sub means below, mandibular is mandibular bone, so below the mandible, and submental. Okay, so the submental is a little bit before the submandibular. There's also jugulo-digastric, which is under the angle of the mandible. Superficial cervical, which overlies the sternomastoid muscle. There's deep cervical, which are deep underneath the sternomastoid muscle. There's posterior cervical, which are lie posteriorly to the edge of the trapezius muscle. And there's supraclavicular, which are just above and behind the clavicle at the sternocleidomastoid muscle. Okay, so again, here's the superficial cervical, and then the deep cervical lymph nodes are here. And then there's posterior cervical. So if you think about the name of these lymph nodes, you can kind of figure out where they are, right? Cervical is the cervical spine. So if you think in your neck, cervical, these are posterior to your cervical spine, okay? And supraclavicular, this is your clavicular bone, and these lie just above your clavicular bone, okay? So all of these lymph nodes form a ring around the head, and they drain lymph primarily from the face and scalp. Remember, the flow of the lymph node goes from the center and then into the side, and all of these drain into the deep cervical chain that you see here. And eventually, the deep cervical chain will empty into the right lymphatic duct and into the thoracic duct. The right lymphatic duct is located on the right side of the body, and the thoracic duct is located on the left side of the body. And those drain into the venous system near the subclavian and internal jugular vein. Okay, so let's see if I have any questions for this chapter. Okay. A nurse is conducting a head and neck assessment on an older, actually we didn't go over this yet, it's the next chapter. So let's go over the next chapter, which is ears, and then we'll do this question. Does anyone have any questions about the lymph nodes at all? No? Okay, so we're going to go on to the next part, which is eyes, ears, nose, mouth, and throat. So first we're going to start with the eyes. So the external anatomy of the eyes, it's a bony orbital cavity surrounded by a cushion of fat which protects the eye. There's the palpebral fissure, which is the elliptical open space between the eyelids, and there's the lower lid margin at the limbus, which borders between the cornea and sclera. The canthus is the corner of the eye, and it is the angle where the lids meet. The inner canthus is the caruncle, a small fleshy mass containing sebaceous glands. The tarsal plates contain meibomian glands, which are modified sebaceous glands that secrete an oily, lubricating material onto the eyelids. The conjunctiva is a transparent, protective covering of the eye. The cornea covers and protects the iris and the pupil, and the lacrimal apparatus provides irrigation to the eye. Okay, so this is a picture of the eye. As you can see here, the upper eyelid, the lower eyelid, the lower canthus, the caruncle here, and the limbus, which is the border between the cornea and the sclera. A very important part of the eye is the iris. The iris is the part of the eye that's responsible for the color of the eye, and it also is responsible for constricting and dilating our pupils. So the color of the eye depends on the pigment that the iris contains when light hits it. For example, my iris, when light reflects off of it, it's brown, so people would say that I have brown eyes. And the center of the iris is the pupil, which is this black circle that you can see right here. Okay? The pupil determines the way in which light will enter into our eyes, and it enables us to see things. Our iris, like I stated earlier, controls the size of the pupil. During the daytime, there's a lot of exposure to sunlight, and the iris is able to adjust the size of the pupil by constricting it, and it constricts it because it does not want to cause damage to the cells that are located in our eye. At nighttime, the iris will cause the pupil to dilate or to widen so that more light can get in and so that we can see better. Okay, so during the daytime, there will be more constriction of the pupil, and this is controlled through the iris. And at nighttime, when there's less light, there will be dilation of the pupil, which is controlled through the iris to allow more light in and allow us to see better. Okay, so when, as nurses, as we're assessing our patients, if we were to take a pen light and to shine it into our patient's eyes, we would expect that the pupil would constrict, right? This is important as a nurse to remember because non-constricting pupils that are exposed to light can indicate something is going on with either the head, maybe there's a head injury, maybe the patient has a stroke or a tumor that's causing the pupils to not constrict. An injury inside of the head can lead to increased intracranial pressure that damages the nerves in the iris. Okay, so let's move on to extraocular muscles. There's 6 muscles that attach the eyeball to its orbit and direct the eye to points of a person's interest. They give eye both straight and rotary movement. Each muscle is coordinated or yoked with one another, or yoked with the other eye, ensuring that when 2 eyes move, their axes always remain parallel, called conjugate movement. 4 straight or rectus muscles are superior, inferior, lateral, and medial rectus muscles, and the 2 slanting or oblique muscles are superior and inferior muscles. The parallel axes are important because the human brain has a binocular single image visual system. The extraocular muscles, the movement of the extraocular muscles are stimulated by 3 cranial nerves. Cranial nerve 6, the abductive nerve, innervates lateral rectus muscle, which abducts the eye. Cranial nerve 4, the trochlear nerve, innervates the superior oblique muscle. And cranial nerve 3, the oculomotor nerve, innervates all the rest, the superior, inferior, and medial rectus, and the inferior oblique muscles. Okay? So these are the muscles that we talked about: the superior rectus, inferior rectus, lateral rectus, and the medial rectus here. And then the oblique muscles kind of go diagonally. And there's the superior oblique muscle and the inferior oblique muscle. And this is the direction of the movement that causes the eye to move. So when the, for example, medial rectus muscle moves, it's moving the eye inwards, and it's innervated by cranial nerve 3. When the inferior oblique muscle moves, it's moving the eye upward and kind of inward here, as you can see. So the arrows are indicating the movement of the eye with these muscles, and it's showing the innervation of these parts of the eye, which cranial nerve innervates them, these muscles. Okay, so let's say you have a patient that is, they're crossing their eyes, right? Which muscles might you be using to cross your eyes? Anyone can type if they want to in the chat box, maybe you can talk. What muscles might you be using to cross your eyes? Yes, right? Maybe the medial rectus, maybe a little bit of the superior oblique muscle. Okay, good. Now we're going to go over the internal anatomy of the eye. The eye is a sphere which contains 3 concentric modes: the outer fibrous sclera, the middle vascular choroid, and the inner nervous retina. Inside the retina is a transparent vitreous body. Only parts accessible to examination as nurses are the sclera anteriorly and the retina through an ophthalmoscope. Okay, so this picture is showing the three layers that we talked about here, the sclera, the choroid, and the retina. I also want to point out the cornea and the lens because those are important in how we see things. The cornea is this bulging part of the eye here, and behind the cornea is the lens. And the space in between the cornea and the lens has this watery substance called the aqueous humor. The corneas and the lens are both convex shapes, and they make sure that the incoming light is transferred to this back part of the eye here. And the back part of the eye has a lot of very light sensitive cells. The back part of the eye is called the retina. In order for an object to look clear, light has to be focused exactly on that back part of the eye and the retina, otherwise it will look blurry. The retina has nerves, mainly the optic nerve, which carries information to the brain. And when the brain receives input from the optic nerve, it's able, through very complex processes, to process an image. Okay, so you have the cornea, lens, they direct light to the back part of the eye called the retina. The retina takes that information and delivers the information to the brain through the optic nerve. Okay? The outer layer of the eye, the inside part of the eye, the internal anatomy of the eye, contains the sclera, and it's a tough, protective white covering. It's continuous anteriorly with smooth, transparent cornea, which covers the iris and the pupil. The cornea is the part of the refracting media of the eye. It bends incoming light rays so that they will be focused on the inner retina. The corneal reflex can be stimulated by contacting a wisp of cotton, and it causes us to blink. The trigeminal nerve, cranial nerve 5, carries afferent sensation into the brain. So it's carrying, afferent means away, it's carrying information away from the brain. The facial nerve, or also known as cranial nerve 7, carries efferent messages that stimulate us to blink. And efferent means it enters, so it's nerve information that's going into the brain. So now we're going to talk about that middle layer of the eye, the choroid. It has dark pigmentation to prevent light from reflecting internally and is heavily vascularized to deliver blood to the retina. The iris functions as a diaphragm. It has a varying open at its center, the pupil. Muscle fibers, we talked about this earlier, contract the pupil in bright light to accommodate for near vision and dilate the pupil when light is dim for far vision. The pupil should be round and regular, and the size is determined by the balance between the parasympathetic and sympathetic chains of the autonomic nervous system. Remember, parasympathetic nervous system is the rest and digest part, and sympathetic nervous system stimulation causes our fight or flight response. So stimulation of the parasympathetic branch through cranial nerve 3 will cause constriction of the pupil, whereas stimulation of the sympathetic branch dilates the pupil and elevates the eyelid. The pupil size also reacts to the amount of ambient light and to accommodation or focusing an object on the retina. Again, we're talking about that middle layer, the lens, which we already said is the biconcave disc. It's located just posterior to the pupil. It's transparent and it serves as a refracting medium, keeping a viewed object in focus on the retina. The anterior and posterior chambers contain a clear, watery aqueous humor produced continually by the ciliary body. The continuous flow of fluid serves to deliver nutrients to the surrounding tissues and to drain metabolic wastes. Intraocular pressure is determined by the balance between the amount of aqueous produced and the resistance to outflow. So it's important to know what the intraocular pressure is in patients with conditions like glaucoma, because when the intraocular pressure is high, there's too much pressure in the eye, it can actually cause damage to the optic nerve, which may result in loss of vision. So that's intraocular pressure is an important measurement to remember. Again, we're going to talk about the retina, the internal anatomy of the eye, the innermost layer. The innermost layer contains the retina. It is the visual receptive layer of the eye, where light waves change into nerve impulses. Remember that back part of the eye that we talked about? Back here, it contains a lot of very light-sensitive cells, and it connects to the optic nerve, which will ultimately send those messages to the brain. The retinal structures are viewed through an ophthalmoscope, and those include the optic disc, the retinal vessels, the general background of the retina, and the macula. The optic disc is the area in which fibers from the retina converge to form the optic nerve. It is located toward the nasal side of the retina, and it has characteristics specific to color, shape, and margins. The retinal vessels normally include a paired artery and a vein extending to each quadrant. The macula is located on the temporal side of the fundus in a slightly darker pigmented region surrounding fovea centralis, which is an area of the sharpest and keenest vision. It receives and transduces light from the center of the visual field. So now we're going to talk about visual pathways and visual fields. Light rays are refracted through the transparent media, the cornea, aqueous humor, which is, remember, that watery substances that's located in between the cornea and the lens, and the vitreous body. And these all strike the back of the eye, the retina. The retina transforms the light stimulus into nerve impulses conducted to the visual cortex. An image is formed on the retina, and it's actually upside down and reversed when it comes in. All retinal fibers collect to form the optic nerve, but maintain the same spatial arrangement. An optic chiasm, at the optic chiasm, which are fibers from both the visual fields, this is where they cross over. The left optic tract now has fibers from the left half of each retina, and the right optic tract contains fibers only from the right. Thus, the right side of the brain looks at the left side of the world. Okay, so this picture is showing how these visual pathways work, and it shows how things from the left side of the visual field are sent through the optic chiasm to the optic tract, and they go to the right side of the brain. And the optic chiasm is where they're crossing over to the right side of the brain. The right visual field takes information from the right side, and then it sends it to the left side of the brain. So that's what this picture is showing. The pupillary light reflex. It is a normal constriction of the pupils when bright light shines on the retina. So remember, we said when light is shown into the pupils, the normal reaction, the expected finding as nurses that we would see in our patients is pupil constriction. Fixation is a reflex direction of the eye toward an object, attracting a person's attention. An image is fixed in the center of the visual field, the fovea centralis. Accommodation is adaptation of the eye for near vision. It is accomplished by increasing the curvature of the lens through movement of ciliary muscles. Although the lens cannot be observed directly, the following components of accommodation can be observed. Convergence, which is motion towards of the axis of the eyeballs, and pupillary constriction. So the next part that we're going to go over is the nose, mouth, and throat. I think the ears, also the ears. So the external ear is called the auricle or pinna. It consists of movable cartilage and skin. Its characteristic shape serves to funnel sounds into its opening, which is called the external auditory canal. The auditory canal is about 2.5 to 3 centimeters long in adults, and it terminates at the eardrum, or the tympanic membrane. It's lined with glands that secrete cerumen, which is a yellow waxy material that lubricates and protects the ear. Cerumen is also known as earwax. The outer one-third of the canal is cartilage. The inner two-thirds consist of bone covered by thin, sensitive skin, and lymphatic drainage of the external ear flows to carotid, mastoid, and superficial cervical nerves. The tympanic membrane, also called the eardrum, separates the external and middle ear. It's a translucent membrane with a pearly gray color. It's oval and slightly concave, and it's pulled in at its center by one of the middle ear ossicles, the malleus. Parts of the malleus show through the translucent drum, the manubrium, and the short process. The pars flaccida is a small, slack, superior section of the tympanic membrane. The pars tensa is the remainder of the tympanic membrane, and it's thicker and more taut. The annulus is the outer fibrous rim of the tympanic membrane. Okay, so this is the picture that shows the external ear. We have the external auditory canal, which then runs through into the tympanic membrane or the eardrum. And then it goes into the middle ear, which we're going to talk about next. The middle ear consists of tiny air-filled cavities inside of the temporal bone. It contains tiny ear bones, or auditory ossicles, the malleus, incus, and stapes. There are several openings that are present. There are openings to the outer ear and to the inner ear eustachian tube. The opening that connects the middle ear, the nasopharynx, and allows passage of air. Normally it's closed, but with with swallowing or yawning, the eustachian tube opens. It has three functions. It conducts sound vibrations from the outer ear to the central hearing apparatus in the inner ear, and it protects the inner ear by reducing the amplitude of loud sounds. The eustachian tube allows equalization of air pressure on each side of the tympanic membrane so that it does not rupture. Now we're going to go on to the inner ear, which is this part over here. Okay? The inner ear contains the bony labyrinth, which holds sensory organs for equilibrium and hearing. Vestibular and semicircular canals within the bony labyrinth compose the vestibular apparatus. The cochlea contains the central hearing apparatus. Although the inner ear is not accessible to direct examination, its functions can be assessed. So, hearing, the auditory system, can be divided into three levels: the peripheral brainstem and cerebral cortex. At the peripheral level, ear transmits sound and converts its vibrations into electrical impulses, which can be analyzed by the brain. Amplitude is loudness, and frequency is the pitch or number of cycles per second. Sound waves produce vibrations on the tympanic membrane. Numerous fibers along the basilar membrane are receptor hair cells of the organ of Corti, the sensory organ of hearing. As hair cells bend, they mediate vibrations into electrical impulses, which are conducted by the auditory portion of cranial nerve 8 to the brainstem. The function at brainstem level is binaural interaction. It locates the direction of a sound in space as well as identifying the sound. Cranial nerve 8 from each ear sends signals to both sides of the brainstem, which are sensitive to differences in intensity and timing of messages from the two ears, depending on the way the head is turned. The function of the cortex is to interpret the meaning of the sound and begin appropriate responses. The pathways of hearing. Normally, the pathway of hearing is through air conduction, which was described previously and is the most efficient. The alternative route is through bone conduction. The bones of the skull vibrate and are transmitted directly to the inner ear and to cranial nerve 8. And this picture is just showing two different pathways of hearing through bone conduction, which takes those vibrations and sends it through nerves to the brain, or through air conduction. Now we're going to talk about hearing loss. There's conductive, sensorineural, or mixed hearing loss. Conductive hearing loss is mechanical dysfunction of the external or middle ear. It is parietal loss because the person is able to hear sound if sound amplitude is increased enough to reach the normal nerve elements in the inner ear. It may be caused by impacts in earwax, foreign bodies, or perforated tympanic membrane, pus or serum in the middle ear, and otosclerosis. Sensorineural or perceptive hearing loss signifies the pathology of the inner ear, cranial nerve 8, or auditory areas of cerebral cortex. An increase in amplitude may not enable a person to understand words. May be caused by proboscis and ototoxic drugs, which affect hair cells in the cochlea. Then there's mixed hearing loss, which is a combination of both the conductive and the perceptive hearing loss. Equilibrium. The labyrinth in the inner ear constantly feeds information to the brain about the body's position in space. It has 3 semicircular canals. If the labyrinth ever becomes inflamed, it feeds the wrong information to the brain, and it may cause the patient to have a staggering gait or vertigo. So remember, our equilibrium may be affected if there's damage to the labyrinth. It may cause a person to have a staggering gait or vertigo, which is dizziness. In infants and in children, the inner ear starts to develop early in the 5th week of gestation. In early development, the ear is posteriorly rotated and lobe set. If maternal rubella infection occurs during the first trimester, it can cause damage to the organ of Corti and can impair hearing. An infant's eustachian tube is relatively shorter and wider and more horizontal than adults, so it is easier for pathogens from the nasopharynx to migrate through to the middle ear. So because of the anatomy of the infant's ear, it's shorter and wider, it's easier for infants to get infection of that inner ear than it is for adults who have a more developed inner ear. The lumen is surrounded by lymphoid tissue, which increases during childhood and is easily occluded. All of these factors place infants at a greater risk for middle ear infections than adults. Infants and young children's external auditory canal is shorter and has a slope opposite to that of adults. Otosclerosis is a common cause of conductive hearing loss in young adults between ages of 20 and 40. It causes a gradual hearing loss and hardening of the foot plate of staples, and it causes them to become fixed in the oval window. This impedes the transmission of sounds and causes progressive deafness. In aging adults, so usually older adults are greater than 65-year-olds, the cilia lining the ear canal become coarse and stiff. Because the cilia are coarse and stiff, there's an accumulation of cerumen or earwax and oxidation of the earwax, which greatly reduces hearing. Cerumen is drier with aging because of atrophy of the apocrine glands. Impacted cerumen is a common but reversible cause of hearing loss in older people. Okay, so let's go over the questions for this chapter. A nurse is conducting a head and neck assessment on an older adult client. Which of the following age-related changes should the nurse expect to find? Remember, we just talked about this, the age-related changes in older adult clients, which may be greater than 65 years old. So what things might we expect to find in the older adult client? Accumulation of cerumen, hearing loss, tender swollen lymph nodes, or increased visual acuity. This is a select all that apply, so there's going to be more than one right answer. Let me put A and B here so you guys can just say like A, B, C, or D. Remember, this is select all that apply, so there will be more than one answer. Yes, Nicole, it would be A and B, right? Because as older adults age, there's a buildup of earwax inside of their ears, which affects their hearing, and they would have hearing loss as a result of this. It's not C or D. We would not expect older adult clients to have tender swollen lymph nodes, and they would actually have decreased visual acuity, not increased visual acuity. Okay, let's go to the next question. A nurse is assessing the extraocular movements of the eye. What nerves would you expect the nurse to assess? Oculomotor, trochlear, abductens, trigeminal, or optic? It's actually cranial nerve 3, 4, and 6, so the first 3. Okay, so this is kind of just a definition question. You guys have to kind of commit to memory what these cranial nerves are responsible for. Okay, so oculomotor, trochlear, and abductens are responsible for the extraocular movements of the eye. A nurse is assessing the pupils of a patient with a traumatic brain injury. What expected findings would the nurse see in a patient with this condition? Will they have dilated fixed pupils? Will they have pupils that are equal and reactive to light? Or will they have red conjunctivae? What do you guys think? Remember, they have a traumatic brain injury. So they have damage to the brain, which may be increasing their intraocular pressure and affecting their optic nerve. Dilated and fixed, right? When you shine the light into their eyes, you might find that their pupils are not constricting when it's exposed to the light because they have this brain injury. Good. The nurse is assessing a client complaining of vertigo and is staggering gait. The nurse can conclude that damage may have occurred to this part of the ear. Is it the labyrinth of the inner ear, the eustachian tube, or the tympanic? What do you guys think? Labyrinth, right? The labyrinth of the inner ear is responsible for our equilibrium. So when there's damage to the labyrinth of the inner ear, you might find patients complaining of vertigo or dizziness, and they might have a staggering gait. Good. Okay, so the next slide that we're going to go over is the breast, axilla, and facial lymphatics. The breasts lie anterior to the pectoralis major and serratus anterior muscles. They are located between the second and sixth ribs, extending from the side of the sternum to the mid-axillary line. The tail of Spence is superior to the lateral corner and projects up and laterally into the axilla. The areola surrounds the nipples, and the Montgomery's glands are small, elevated sebaceous glands which secrete protective lipid material during lactation. Okay, so this is showing a picture of the breasts and the anatomy that we just talked about. So the axillary tail of Spence is kind of in this upper left-hand corner. This is made of adipose tissue. and then the areola is surrounding the nipple, and the Montgomery glands are those sebaceous glands that secrete lipids during lactation. And as you can see here, it's located between the second and sixth ribs. The breast is composed of glandular tissue, fibrous tissue, and adipose tissue. The glandular tissue contains 15 to 20 lobes radiating from the nipple, and these are composed of lobules. Cooper's ligaments are fibrous bands which extend vertically from the surface to attach on the chest wall muscles. The lobes are embedded into the adipose tissue. The breast may be divided into 4 quadrants by imaginary horizontal and vertical lines intersecting at the nipple. The upper outer quadrant is the site most commonly where breast tumors occur. So that's important to remember. So this is talking again about how the breast is divided. It can be divided into 4 quadrants: upper inner, upper outer, lower inner, and lower outer. And it's important to remember that the upper outer quadrant is the site where breast tumors are most commonly occurring. The lymphatics. The breast has extensive lymphatic drainage. There are 4 groups of axillary nodes present: central axillary nodes, pectoral, subscapular, and lateral. From the central axillary nodes, drainage flows up to the infraclavicular and supraclavicular nodes. Okay, so this picture is just showing the regional lymphatics of the breast. During embryonic life, ventral epidermal ridges or milk lines are present and curve down from the axilla to groin bilaterally. It develops along the ridge over the thorax, and the rest of the ridge usually atrophies. Supernumerary nipple occasionally persists and is visible along the track of the mammary ridge. At birth, the only breast structures present are the lactiferous ducts within the nipple. In adolescence, at puberty, estrogen stimulates breast changes. Temporal asymmetry may occur where occasionally one breast grows faster than the other. And Tanner staging is the 5 stages of breast development that are included as levels of sexual maturity. Hilarchy is breast development, and it usually precedes menarche, which is when females get their periods by about 2 years. Pregnant women. Breast changes in pregnant women usually start at the 2nd month of pregnancy and are usually an early sign for most women. Colostrum may be expressed after the 4th month. Colostrum is a thick yellow fluid that is a precursor for milk, and it contains the same amount of protein and lactose, but practically no fat. Breasts produce colostrum for the first few days after delivery. They are rich in antibodies, and they protect the newborn against infection. So that's why it's usually they will encourage women to breastfeed versus bottle feed, because the breast milk contains this colostrum, which is important for the immune protection of newborns. Lactation is milk production of the breast, and it usually begins 1 to 3 days postpartum. It has a whitish color from the emulsified fat that it contains and from the calcium that it contains. In aging women, after menopause, the ovarian secretion of estrogen and progesterone begins to decrease, and the breast tissue begins to atrophy or get smaller. The decreased breast size makes inner structures more prominent, and a breast lump that may have been present for years is suddenly palpable. Around the nipple, the lactiferous ducts are more palpable and feel firm and stringy because of fibrosis and calcification. Also, what occurs is the axillary hair begins to decrease. In the male breast, the rudimentary structure consisting of a thin disc of undeveloped tissue underlying the nipple. Gynecomastia may occur in the male breast, which is breast enlargement in the female patient. It may occur during adolescence. And it is common during adolescence for the breast tissue to temporarily enlarge. It's usually unilateral and temporary, and reassurance is necessary for the adolescent male who may be focusing on the body image. However, it may be common during adolescence, but as men begin to age, you would not expect this to be in the aging male. And what may be contributing to gynecomastia in the aging male could be testosterone deficiency. So that's important to remember too. Remember that it's common in adolescence, but in an aging male, you should not have gynecomastia and may be due to an underlying testosterone deficiency. Okay, so let's go over these next questions. And then I want to move on to the lungs and heart because I think that's going to take a little bit more time. So what area of the breast is the most common site of breast cancer tumors? Yes, remember, the upper outer quadrant is the most common site of breast cancer tumors. Okay, so let's move on to lungs and hearts. Okay. So the position and surface landmarks of the lungs. Remember that it's located within the thoracic cage. The thoracic cage is a bony structure with a conical shape, which is narrower at the top. It's defined by the sternum, which has 12 pairs of ribs and 12 thoracic vertebrae. The first 7 ribs attach to the sternum by costal cartilages, and ribs 8, 9, and 10 attach to the costal cartilage above. Ribs 11 and 12 are floating with 3 palpable tips. Costochondral junctions are the points at which the ribs join their cartilages, and they are usually not palpable. Now we're going to talk about the anterior thoracic cavity. You have a suprasternal notch, which you can actually palpate on yourselves. It's the U-shaped depression just above the sternum and between the clavicles. The sternum is the breastbone. It has different parts. There's the manubrium, the body, and the exophoid process. Then you have your manubriosternal angle, also known as the angle of Lewis. It is the articulation of the manubrium and the sternum, and is continuous with the second rib. You can identify the angle of Lewis by palpating lightly to the second rib and sliding down to the second intercostal space. The angle of Lewis also marks the site of tracheal bifurcation into the right and left main bronchi. It corresponds with the upper border of the atria of the heart, and it lies above the 4th thoracic vertebrae on the back. The costal angle is the right and left costal margins which form an angle where they meet in exophoid process. Okay, so this is showing everything that we just talked about. If we start from the top, you have your clavicles. In between the clavicles, just above this manubrium of the sternum, is that U-shaped suprasternal notch, and then you have your ribs. 1, 2, 3, 4, 5, 6 attached to the costal cartilage, as you can see here. And then 11 and 12 are free floating, and 8, 9, and 10 are attaching to the costal cartilage of the ribs above it. Okay? At the bottom of the sternum is the exophoid process. You have your diaphragm here. You can see this red kind of squiggly line, the dome of the diaphragm. Okay? And then the angle of Lewis, which is the sternal angle that on the sides we're talking about, is right here. It's next to the second rib. Now we talked about the front, now we're going to talk about the posterior or the back part of the thoracic cavity. There's the vertebra prominence. If you flex your head and feel for the most prominent bony spur protruding from the base of the neck, this is the vertebra prominence. The spinous processes, if you count down these knobs in the vertebrae, which stack together to form the spinal column, these are the spinous processes. The inferior border of the scapula The scapula are located symmetrically in each pneumothorax, and the 12th rib, you can actually feel it now if you palpate midway between the spine and a person's side. You can feel the free tip of the 12th rib. Okay, so the scapula again, the clavicle. We have the cervical end of the cervical spine, C7, and then we begin our thoracic spine. T stands for thoracic, so you know this is thoracic vertebra 1. Okay, and that goes all the way down to T12. And then, remember we said that you can palpate the end of your 12th rib because it's free flow. And the reference lines, you can use these reference lines that we discussed to pinpoint the finding vertically on the chest. For the anterior chest, it's important to note the mid-sternal and the mid-clavicular line. And on the posterior chest, you can use the vertebral or the mid-spinal line and the scapular line as reference lines when you're referring to something. If you lift up the person's arm by 90 degrees and divide laterally the chest by 3 lines, you'll have the anterior axillary line, the posterior axillary line, and the mid-axillary line. Okay, so these are, this picture is a good picture which shows the anterior reference lines. Remember, your clavicle is this bone here, so the mid-clavicular line splits that clavicle in half. Your axillary is your armpit, and that's right here. So this is the mid-axillary line. And the sternum, remember, is right in the middle, and it's this is the mid-sternal line that you can use as reference lines. Something that you'll probably come into practice when you're all nurses and you're doing your EKGs, you're going to use these reference lines to place your electrodes when you're setting up patients to do EKG, for example. Okay, and then again, we talked posteriorly, the reference lines on the back, vertebral line, and the scapular line. The scapular here and your vertebral spine is in the middle, so this is the vertebral line and this is the scapular line. And if you turn the person sideways and you ask them to raise their arm, the anterior axillary line is the one in the front, mid-axillary line is in the middle, and posterior axillary line is all the way in the back. The thoracic cavity contains the mediastinum, which is the middle section of the thoracic cavity, which contains the esophagus, trachea, heart, and great vessels. The lungs are the right and left pleural cavities, which contain the lungs. Note the borders at the apex, base, and lateral and posterior positions. Now, there's different lobes of the lung. They're paired but not symmetrical structures. The right is shorter than the left because of the underlying liver. And remember that the left lung is narrower than the right because the heart wall is to the left. So I have a picture that I found that I just want to show you guys really quickly that shows the lobes of the lungs. So remember, the right lung is shorter than the left because the liver is over here. And the left lung is a little bit more narrow because if you see this kind of bulge here, that's where the heart is. So the left is more narrow and it is contains because of the heart, and the right is a little bit shorter than the left because of the liver. So here, the right has 3 lobes and the left has 2 lobes. So remember, left has less. L equals less. This is just talking again about the lobes of the lung. The anterior chest has the oblique fissure, which crosses the 5th rib in the mid-axillary line and terminates at the 6th rib in the mid-clavicular line. The posterior chest is mostly all lower lobes. So if you want to listen to the patient's lower lobes, it's better if you assess them by listening. Rather anteriorly, you should assess them posteriorly because you can listen to those lower lobes the best from the back. The lateral chest is the lung tissue that extends from the apex of the axilla down to the 7th or 8th rib. And the left lung, as we discussed, only has 2 lobes. It has no middle lobe. The anterior chest contains mostly the upper and middle lobe with very little lobe. The posterior chest contains almost all lobes. The pleurae form an envelope between the lungs and the chest wall. The visceral pleura lines the outside of the lungs and it dips into fissures. The pleural cavity normally has a vacuum or a negative pressure which holds the lungs tightly against the chest wall. The pleural cavity is a potential space filled with only a few mLs of lubricating fluid. Okay, so I have a picture here that I just wanted to show you really quickly. This is the lung here. The visceral pleura adheres to the outside surface of the lung, so the visceral pleura attaches to the lung itself, and then the parietal pleura attaches to the chest cavity. And in between the parietal and the visceral pleura is the pleural cavity. And normally the pleural cavity has a thin amount of fluid, normally about 10 mLs, which creates a negative pressure, and it keeps the lungs tightly adhered to the chest wall. So as you can see in this picture, it fills with fluid, and it helps to lubricate the lungs when you inhale and exhale, and it prevents the different flora of the lungs from rubbing up against each other. Now, we're going to talk about the trachea and the bronchial tree. Sorry, I just want to make sure that. The trachea lies anterior to the esophagus and is about 10 to 11 centimeters long in the adult. The right main bronchus is, so the trachea, you're the trachea, and it separates into the right and left bronchi. The right bronchus is shorter and wider than the left bronchi, which is more vertical. The trachea and bronchi are transport gases between the environment and the lung parenchyma. The trachea and bronchi are not involved in gas exchange, so they refer to them as dead space, or space that is filled with air, but it's not available for gaseous exchange. And this is about 150 mLs of air in the adult. The bronchial tree protests alveoli from small particulate matter in inhaled air, and it is lined with goblet cells that secrete mucus. The acinus is the functional unit that consists of bronchioles, alveolar ducts, and the alveolar sacs and alveoli. So we're going to talk about the mechanics and function of respiration. There's 4 major functions of the respiratory system. The major one being supplying oxygen to the body for energy production, and removing carbon dioxide as a waste product of energy reactions. It also is important in maintaining homeostasis, or the acid-base balance of the arterial blood. By supplying oxygen to the blood and eliminating excess carbon dioxide, respiration helps to maintain our pH, or acid-base balance of the blood. It also is important in maintaining heat exchange. Okay, so the 4 major functions: supply oxygen, remove CO2, and maintain our pH balance and maintain our heat exchange. Does anyone know what the normal pH balance, the normal pH of the blood should be? The normal pH of the blood should be between 7.35 and 7.45. So if you have a patient who's having difficulty removing the carbon dioxide, you might see their pH go low, or their blood become more acidic because they're not able to breathe off that excess CO2. So their pH will be less than 7.35. Okay, and this is a good picture that's showing the different structures of the respiratory system. So remember, we talked about the trachea. The trachea branches off into the right and left bronchial tree. So as we inhale air, it goes through our noses and mouth and goes through our upper respiratory system. And our upper respiratory system consists of our nose, our nasal cavity, our larynx, and our pharynx. From there, it enters the lower respiratory system, and the lower respiratory system consists of the trachea, our bronchial tree, and our lungs. From the trachea, it breaks off into the right and left bronchial tree. The primary bronchi branch off into the lobar bronchi, which are known as secondary bronchi, and then further into submental bronchi. So what's going on is the right and knee bronchi are further divided into smaller bronchi. And eventually they branch off into even smaller airways known as bronchioles. The bronchioles connect to the alveolar sacs that contain alveoli, and the alveoli is the site of the gas exchange. Capillaries are embedded into the alveoli to form an alveolar capillary membrane. Okay? If gas exchange, and here's the picture of the alveoli, if gas exchange is impaired at the alveoli, the levels of O2 and CO2 will be affected. A patient may become hypoxemic. Does anyone know what hypoxemic means? You can type it into the chat box. What does hypoxemic mean? They'll have low oxygen, right? So if the gas exchange is impaired at the alveoli, they might become hypoxemic, or they'll have low levels of oxygen. Or they might become hypercapnic. Does anyone know what hypercapnic means? Feel free to type in the chat box if you know what hypercapnic means. Hypercapnic means they have too much CO2, right? So again, if the alveoli are impaired, the gas exchange will be affected, and they will have not enough O2, or they might have too much CO2. And too much CO2 is called hypercapnic. Not enough O2 is called hypoxemic. The CO2 levels are too high, and the medulla and the pons in the brain are stimulated to increase the rate and depth of respirations. So increased CO2 levels will cause hyperventilation. And hyper means increased, ventilation means respiratory rate. So to breathe off the excess CO2, the brain will stimulate the respiratory system to breathe faster. So the respiratory rate will be increased to breathe off the excess CO2. Does that make sense? And that's kind of what these next slides are talking about. It's talking about the control of respirations. The major feedback loop of the control of respirations is through humoral regulation, or change in carbon dioxide and oxygen levels in the blood, and less importantly, the hydrogen ion level. A normal stimulus for us to breathe is an increase in carbon dioxide in the blood, or hypercapnia. The decrease of oxygen in the blood, which we already know is hypoxemia, also increases respirations, but it's less effective than hypercapnia. Okay. When we breathe, there's also a change in our chest size. So air rushes into our lungs as the chest increases through inspiration, and is expelled from the lungs as the chest recoils, or what is known as expiration. Mechanical expansion and contraction of the chest cavity alters the size of the thoracic container in two dimensions, vertically and anterior-posteriorly. Okay, so let's look at this picture. When we breathe and exhale, or inhale and exhale, there's an increase in our vertical diameter because the intercostal muscles are elevating, right? The intercostal muscles are elevating our ribs, which is increasing our vertical diameter. What's also going on is our sternocleidomastoid muscle is getting involved, and it's helping to elevate those ribs as well. And then, because of the diaphragm, it descends as it contracts, it goes downwards when we inhale, it increases the anterior posterior diameter, which is the horizontal diameter of the thoracic cavity. So again, just to recap, there will be an increased vertical diameter with inspiration. The intercostals, external intercostals will elevate, and the sternocleidomastoid muscles will also contract and move the ribs upward, and the diaphragm will descend or as it contracts, and it will increase the anterior posterior diameter. On the other hand, with expiration, the intercostals will depress the ribs and move them down, and the external oblique and abdominal rectus muscles will ascend rather than descend like it does with inspiration. Okay, so let's do some lung questions. Okay. True or false? During gas exchange, carbon dioxide is transported across the capillary membrane to be exhaled, while oxygen is transported across the capillary while oxygen is transported across the capillary membrane to attach to the red blood cells. Is this true or false? What do you guys think? Carbon dioxide is exhaled while oxygen is inhaled. Is this true or false? True, right? We breathe off the carbon dioxide and breathe in the oxygen. True or false? During inhalation, the diaphragm contracts upwards to create positive pressure in the chest, which allows the body to inhale oxygen. What do you guys think? False, right? What does it do? It doesn't contract upwards, it contracts what? Downwards. And it's actually not creating a positive pressure, it's creating a what? Is it positive or negative? What do you guys think? Negative, right? The diaphragm contracts downwards to create a negative pressure in the chest, which allows the body to inhale oxygen. Good. The inner layer that surrounds the lung itself is called the parietal visceral flora, or is it called the pleural cardium or the lobar bronchi? What do you guys think? A, B, C, or D? The inner layer that surrounds the lung itself is E, right? Let's look at this picture again. The visceral flora adheres to the lung itself. The parietal flora adheres to the chest wall. And in between the visceral and parietal flora is the pleural cavity, which contains a small amount of lubricating fluid. True or false? The left has 3 lobes and the right lung has 2 lobes. False, yes. The left lung has 2 lobes and the right lung has 3 lobes. Remember, left equals less. Okay, you can remember that. Okay, so now we can move on, since we have like a half hour left, we can move on to the heart and the great vessels. Okay, so the position and surface landmarks of the heart, there's the precordium, which is the area on the anterior chest overlying the heart and the great vessels. The heart has 4 chambers, 2 atria and 2 ventricles. The atria are on the top and the ventricles are on the bottom. The great vessels are the major arteries and veins connected to the heart. Blood vessels are arranged in 2 continuous loops. There's pulmonary circulation and there's systemic circulation. This is showing the precordium here, and then the base of the heart, which is at the top, and the apex of the heart, which remember kind of starts to go into the left side of the lung, and it's the reason why the left lung is more narrow. The heart wall has numerous layers. There's the pericardium, which is the tough, fibrous, double-walled sac that surrounds and protects the heart. There's the myocardium, which is the muscular layer of the heart, and there's the endocardium, which is a thin layer of endothelial tissue that binds the inner surface of the heart chambers and valves. So the endocardium is the innermost layer, the pericardium is the double-walled sac that lines the outside of the heart. The heart has 2 pump systems. Each side of the heart has an atrium and a ventricle. The atrium is a thin-walled reservoir for holding blood, and the ventricle is a thick-walled muscular pumping chamber. The heart chambers and valves. There are 4 chambers separated by valves, whose main purpose is to prevent the backflow of blood. The valves are unidirectional, and the valves open and close passively in response to pressure gradients in moving blood. There are 4 valves in the heart, and each of those valves sit in between the atria and the ventricles, or between the ventricles and the aorta, or the pulmonary veins, or the pulmonary arteries. There are 2 AV valves that separate the atria and the ventricles. There's the tricuspid valve, which is the right atria ventricular valve, and there's the bicuspid or atrial valve, the left AV valve. The valves are made of thin leaflets and are anchored by collagenous fibers called chordae tendineae to papillary muscles embedded in the ventricle floor. The AV valves open during the heart's filling phase, or diastole, to allow the ventricles to fill with blood. So remember, the AV valves during diastole are open, and they're allowing blood to flow in from the atria to the ventricles. During the pumping phase, or systole, the AV valves close to prevent regurgitation of blood back up into the atria. So that's important to remember. During diastole, the AV valves will be open, but during contraction or systole, the AV valves will be closed to prevent the backflow of blood from the ventricles into the atria. The semilunar valves are valves that are set between the ventricles and the arteries. Each valve has 3 cusps that look like half moons. The pulmonic valve is the semilunar valve in the right side of the heart, and the aortic valve is a semilunar valve in the left side of the heart. They are open during pumping or systole to allow blood to be ejected from the heart. No valves are present between the vena cava and the right atrium, or between the pulmonary veins and the left atrium. Abnormally high pressure in the left side of the heart gives a person symptoms of pulmonary congestion, whereas abnormally high pressure in the right side of the heart shows in neck veins and the easy abdomen. Okay, so remember, if the left side of the heart has a lot of pressure that it has to pump against, that blood flow, right, instead, let's look at the left side, that blood flow, instead of going forward to the aortic valve and into the aorta to the rest of the body, the blood will start to back up and it will start to sit in the lungs. If a person has high pressure on the right side of the heart, the blood will not be able to pump forward into the pulmonic valve and into the pulmonary arteries and go into the lungs. It will start to backflow into the rest of the body. So if a person has issues with the right side of the heart, you will see systemic congestion, and it will show in the neck veins. They might have distended jugular veins, or they might have something called ascites, which is fluid buildup in the abdominal cavity. So remember, if there's left-sided issues with the heart, they will have pulmonary congestion. If there's issues with the right side of the heart, they will have systemic congestion. Okay, so let's look at these different chambers. We have the atria, which are at the top, and the ventricles at the bottom. Then they are separated by valves. The mitral valve sits between the left atrium and the left ventricle, and on the right side, the tricuspid valve separates the right atrium and the right ventricle. Now, under systole, the right ventricle will contract, and all the blood that was in the right ventricle will push forward through the pulmonic valve and into the pulmonary arteries, which are right here. And the pulmonary arteries will send that blood to the lungs to be oxygenated. On the left side of the heart, if the left side of the heart contracts, all the blood that was sitting in the left ventricle will push forward into the aortic valve into the aorta and will go to the rest of the body because that blood has come from the lungs and it's already oxygenated. Unoxygenated red blood drains into the vena cava and follows a route of venous blood. From the liver, it goes into the right atrium. So remember, right now we're talking about unoxygenated blood. So this is blood that has come from the superior and inferior vena cava and it's entering the right atrium to be sent to the lungs to be oxygenated. So when it's arriving to the right atrium, it's unoxygenated and it's arriving from the liver to the inferior vena cava. From the right ventricle, the right atrium, it goes into the right ventricle. Venous blood flows through the pulmonic valve to the pulmonary artery. Okay? The lungs then oxygenate the blood and they send it back to the heart, to the left atrium. Arterial blood flows through the mitral valve, which separates the left atrium from the left ventricle, and then it goes into the left ventricle. From the left ventricle, it goes into the aorta, and the aorta delivers oxygenated blood to the body. So as you can see, the circulation flows like a continuous loop, and it moves by continuous shifting pressure gradients. So that's what this picture is showing. It's showing the route of blood flow through the body. The blue is blue because it's unoxygenated. So when it's coming from, this is the inferior vena cava. Up here is the superior vena cava. It's delivered to the right atrium, right, into the right ventricle, through the pulmonary artery, where it goes to the lungs. In the lungs, the blood goes through gas exchange at the level of the alveoli, and it's sent back to the heart through the pulmonary veins. The pulmonary veins bring it to the to the left atrium, to the left ventricle, through the aorta, and then it goes to the rest of the body. Now we're going to talk about the cardiac cycle. Remember, diastole is when the ventricles are relaxed and are filling with blood. There's a protodiastolic filling, which is an early passive phase, and there's presystole or atrial systole, also referred to as atrial kick. The systole is the heart's contraction, and it's when blood is pumped from the ventricles, fills pulmonary and systemic arteries. It accounts for 1/3 of the cardiac cycle. Note that atrial systole occurs during ventricular diastole, and this can be confusing, but it is important. For a brief moment, all 4 valves are closed and the ventricular walls undergo isometric contraction. And this contraction is when contraction occurs against a closed system, and it builds up high pressure in the ventricles. Isometric relaxation was all 4 valves are closed and the ventricles relax. The same events occur on both sides of the heart. The right side requires lower pressure and sequence occurs slightly later. Now the heart sounds. The first sound that you'll hear occurs with closure of the AV valves, and it signals beginning of systole. The mitral component of the first sound, M1, slightly precedes the tricuspid component, T1. The second heart sound occurs with closure of the semilunar valves, and it signals the end of systole. The aortic component of the second sound, A2, slightly precedes the pulmonic component, P2. S2 can be heard loudest at the base of the heart. The effects of respiration affect the heart sounds. The volume of the right and left ventricular systole is just about equal but can be affected by respiration. Consider the phrase more to the right and less to the left. Now there's extra heart sounds. Normally a person should only have 1 and 2, lub-dub. S1 is lub, S2 is dub. But extra heart sounds can occur. For example, S3 occurs when ventricles are resistant to filling during early rapid filling phase, or protodiastole. It occurs immediately after after S2, when the AV valves open and atrial blood first pours into the ventricles. There's also an extra heart sound called S4, which occurs at the end of diastole and presystole when ventricular are resistant to filling. And S4 occurs just before S4. These extra heart sounds are called murmurs, and they can be heard as gentle blowing or swooshing sounds on the chest wall. Conditions that create turbulent blood flow and collision currents can cause murmurs. And conditions that can result in murmurs are conditions that increase the velocity of blood, decrease the viscosity or the thickness of the blood, or they can result from structural defects in the valves. So as an example, something that decreases the viscosity of the blood is something like anemia, where there's not as many red blood cells present and the blood is not as thick. In someone with anemia, you might hear a murmur. Characteristics of sound. All heart sounds are described with the frequency or pitch, high or low, the intensity or loudness, loud or soft, and the duration. They're very soft, very short for heart sounds, or silent periods or longer. It can also be characterized by timing, such as during systole or diastole. The heart has a unique ability, or automaticity. It can contract by itself, independent of any signals or stimulation from the body. It contracts in response to an electrical current conveyed by a conduction system. Specialized cells in the SA node may disappear in the leukemia and initiate an electrical impulse. Because the SA node has an intrinsic rhythm, it is called the pacemaker of the heart. ECG waves arbitrarily labeled APQRST stand for the P wave, which stimulates depolarization of the atria. The PR interval is from the beginning of the P wave to the beginning of the QRS complex. And the QRS complex shows the depolarization of the ventricles. The T wave shows the repolarization of the ventricles, and all these electrical events later precede mechanical events in the heart. So I have a picture I can show you guys. The P wave, again, the SA node is here, and this is the AV node. It's activating the atria through electrical impulses. The QRS complex, which looks like this on the EKG, activates the ventricles, and the T wave is known as the recovery wave. The pumping ability of the heart is measured through cardiac output. In the resting adult, the heart normally pumps between 4 to 6 liters of blood per minute throughout the body. The cardiac output can be calculated by multiplying heart rate by stroke volume. The heart can alter its cardiac output to adapt to metabolic needs of the body. Preload and afterload affect the heart's ability to increase cardiac output. The preload is how much blood that is coming into the heart. It is the venous return that builds during diastole. According to the Frank-Starling law, the greater the stretch, the stronger the heart's contraction. So the greater the preload, the stronger the heart will contract. This increased contractility results in an increased volume of blood ejected, or an increased stroke volume. Afterload is the opposing pressure the ventricle must generate to open aortic valves against higher aortic pressures. So afterload is the resistance that the heart must overcome to get blood out of the heart. It is the resistance against which the ventricle must pump its blood. How hard the heart has to work to get blood out to the body. So afterload can be increased in conditions like hypertension, because there's increased resistance in the vasculature, and the heart has to pump harder against that resistance to get blood out. Preload, for example, might be increased in things like fluid overload, where there's a lot of volume in the body. It increases the venous return that's going to the heart. Now we're going to talk about the neck vessels. The carotid artery pulse has different characteristics of its waveform. It has a smooth, rapid upstroke. Its summit is rounded and smooth, and its downstroke is more gradual and has a dicrotic notch caused by closure of the aortic valve. The jugular venous pulse and pressure. It's empty, unoxygenated blood directly into the superior vena cava. The two jugular veins are present on each side of the neck. There's a left jugular vein and a right jugular vein. And there's 5 components to the jugular pulse. The A wave reflects atrial contraction because some blood flows backward to the vena cava during right atrial contraction. The C wave or ventricular contraction is backflow from the bulging upward of tricuspid valve when it closes at the beginning of ventricular systole. The X wave is the descent that shows atrial relaxation when the right ventricle contracts during systole and pulls the bottom of the atria downward. The V wave occurs with passive atrial filling because of increasing volume in the right atria and increased pressure. The Y descent reflects passive ventricular filling when tricuspid valve opens and the blood flows from the right atrium to the right ventricle. Okay, so now we can go over some questions. So, what part of the heart delivers unoxygenated blood to the lungs? Is it the pulmonary artery, pulmonary vein, the aorta, or the left ventricle? I'll put A, B, C, or D so you can say which one. Do you guys know, is it A, B, C, or D? What do you think? The part of the heart that's delivering unoxygenated blood to the lungs. It's actually A. So you can remember this by arteries carry blood away. The pulmonary artery, sends the blood away from the heart to the lungs to be oxygenated, and the pulmonary vein actually brings it back to the heart when it's getting oxygenated. Blood enters on the left side of the heart through the blank and enters the left atrium. It then passes through the blank to enter the left ventricle. So blood enters on the left side of the heart through the blank to the left atrium, and then it passes through the blank to enter the left ventricle. Maybe I should bring this picture up and you guys can see. Let's see. Okay, so blood enters on the left side of the heart through the pulmonary vein, goes into the atrium, and then it passes through the mitral valve Mitral valve is on the left side of the heart. The tricuspid valve is on the right side of the heart. So blood enters on the left side of the heart through the pulmonary vein and enters the left atrium, but then passes through the mitral valve to enter the left ventricle. Okay? Does that make sense? What part of the heart delivers richly oxygenated blood to the body? Is it the tricuspid valve, the superior vena cava, the aorta, or the pulmonary artery? You can type in A, B, C, or D, or 1, 2, 3, 4, whatever. C, right? The blood goes from the left ventricle once it's oxygenated through the aorta to be sent into systemic circulation. It's not the tricuspid valve because where's the tricuspid valve? Between which two ventricles? Which atria, which ventricle? Is the tricuspid valve on the right or the left? Right. The mitral valve, like we had in the last question, is on the left side, but the tricuspid valve is on the right side. That they separate the atria from the ventricles. The superior vena cava is actually delivers unoxygenated blood into the right atrium, and the pulmonary artery, remember, is what leaves from the right ventricle and delivers unoxygenated blood to the lungs to be oxygenated. Okay? True or false? Pulmonary veins take unoxygenated blood away from the heart. False, right? What takes unoxygenated blood away from the heart? Which vessel did we talk about that takes the unoxygenated blood away from the heart? It leaves the right ventricle. Pulmonary artery, right? So right atrium, right ventricle, pulmonary artery, which goes to the lungs, and the lungs bring it back with the pulmonary veins oxygenated. So this is false because it takes oxygenated blood away from the lungs to the heart. What part of the heart delivers oxygenated blood to the heart? Pulmonary artery, right? We just went over this. The pulmonary artery delivers oxygenated blood back to the heart. On the right side of the heart, blood flows from the right ventricle to the blank. A, B, C, or D? Right. It flows through the pulmonic valve to the pulmonic artery where it goes to the lungs to be oxygenated. Why is it not A? It's not A because the tricuspid valve sits in between the right atrium and the right ventricle, so blood cannot flow. Right? The question is asking where is the blood starting? You have to focus on where the blood is started, right? So this sits in between the atrium and the ventricle. That's why it would not be A. Okay. True or false? The atria are located below the ventricles. False, right? Okay, how about this? A nurse is performing a cardiac assessment on a patient with anemia. She hears a low swooshing sound. The nurse knows that this heart sound may be referred to as what? A, B, C, or D? A, right? B is our expected S1 and S2 are normal heart sounds. S3 and S4 are extra heart sounds. But a murmur is a patient with anemia who has low red blood cells. The viscosity of the blood is decreased, so the blood is thinner, which increases the risk of having murmurs. And it's called a physiologic murmur because it can resolve with treatment. It might not be permanent, it can resolve as the patient gets treated. So as the patient with anemia gets a blood transfusion, the murmur may resolve. You may not hear it anymore when you listen to their heart sounds. Okay, we only have one more chapter left to do, and that's the lymphatic system. So I'm going to try and go through this kind of quickly because I have to leave at 12, but if we go a little bit over, that's okay. And then I only have 2 more questions for the lymphatic system, and then next week there's another session at the same time for the remaining chapters in this series, which are, let's see, the abdomen, rectum, prostate, musculoskeletal system, neurologic system, and then the male and female genitourinary system. Okay, so these ones we'll go over next week. So the structure and the function of the arteries. The heart pumps freshly oxygenated blood through the arteries to all body tissues. The function of arteries is to supply oxygen and essential nutrients to tissues. It's accessible to examination are the temporal and carotid arteries, the arteries in the arm, which are brachial bifurcates into ulnar and radial, arteries in the leg, femoral, popliteal, anterior tibial to dorsalis pedis, and posterior tibial to plantar arteries. Peripheral arterial disease affects non-coronary arteries and refers to arteries affecting organs. Okay, so periphery means away from the center, arteries. So periphery is the limbs that are affected by arterial disease. And remember, periphery is away from the center. So this disease affects the limbs. Okay? This is just going over the arteries in the arm. That's what this picture is showing. So the brachiocephalic artery, as you can see here, branches off the aortic arch and it divides into the common carotid artery, which supplies blood to the head, and then it divides into the subclavian artery, which supplies blood to the upper extremities. As you can see, the subclavian artery continues and it perfuses different parts of the arm. It becomes the axillary artery, and then which supplies the axillary artery supplies the armpit and the thorax. And then the axillary artery becomes the brachial artery, which can be palpated at the antecubital fossa, which is right here. That's why this is circled and it says pulse site, because you can palpate the brachial artery at this site. Okay? The brachial artery splits off into the radial and ulnar artery, which supply the forearm. And then these main arteries, as you can see here, kind of split off into smaller branching arteries, which supply other parts of the arm and of the hand. The vessels in the leg come from the aorta. Here you can see the abdominal aorta. It's starting here. The abdominal aorta branches into the common iliac artery, which becomes the femoral artery, right? And this site is circled because this is the pulse site where you can assess the femoral artery. It's just underneath this iliac crest here, kind of near the patient's groin. Then the femoral artery becomes the popliteal artery, right? So it's better visualized from the posterior view. And that can be palpated in the back of the knee. That's why this is circled and it says pulse site, because the popliteal artery can be palpated behind the knee. The tibial artery is next, right? It supplies the tibia, and finally the dorsalis pedis artery, which supplies the foot. Commonly, the dorsalis venous, you'll hear to referred as pedal pulses, and it can be felt on the top of the foot. These can also be assessed by Doppler. The Doppler uses sound waves to bounce off of moving objects in the body, and the blood cells are moving objects, so it uses sound waves which bounce off of our blood cells and help to amplify the sound there. And the Dopplers are used to assess pulses if they cannot be palpated by touch. For example, if you have a patient who has a lot of edema, it might be difficult to palpate a pulse because of the fluid accumulation, in which case a Doppler might be useful. Okay, and then on this side we see the venous flow. Remember, venous returns blood to the heart, and it is unoxygenated. And that's why the veins here are depicted as blue, because they are low in oxygen content. The course of veins parallels that of arteries. The body has more veins, and the veins lie closer to the skin surface. The function of veins is to drain deoxygenated blood and its waste products from tissues and to return it to the heart. The veins are called capitans vessels because of their ability to stretch. So accessible to examination are the jugular veins in the neck and the veins in the leg, the femoral and popliteal, great and small saphenous, and the connecting veins that join these two sets, the peripherals, which we see here. Okay? The structure and function of venous flow, it's a low pressure system. It's a mechanism to keep blood moving, and venous flow moves by contracting skeletal muscles, the pressure gradient caused by breathing, and by intraluminal valves. In the legs, this mechanism is called calf pump or peripheral heart. Dilated or tortuous varicose veins create incompetent valves, which lead to increased venous pressure, which further dilates the vein. So this is just a picture showing the different venous flow. The venous flow is affected by the skeletal muscle contraction. So as you can see here where it says 1, skeletal muscle pressure puts pressure on the veins and opens up these valves. It propels the unoxygenated blood upwards. That's why this arrow is facing up. It propels the blood upwards towards the heart. During inspiration, which is the second mechanism that controls venous flow, venous return increases as the thoracic cavity pressure becomes more negative. Because there's a negative or reduced interthoracic pressure, more blood is drawn into the heart during inspiration. It causes greater venous return or more blood flow to return to the heart because there's less resistance or less pressure that the venous flow has to overcome. Okay? And then the valves are the third way that venous flow is controlled because they open and close. They open when blood flows to the heart and close to prevent backflow of the blood, as what might happen under gravity. Now we're just going to quickly go over the lymphatic system. The lymphatic system is a drainage system that removes excess fluid from the body and returns it to the vascular system to be circulated. The lymphatic system has both circulatory and immune functions. It is a subset of both the circulatory and immune system. Okay, so here it's saying exactly this. It's retrieving excess fluid and plasma proteins from the interstitial spaces and returns it to the bloodstream. There's a pressure gradient difference between the arterial and venous end of the capillary beds, and there's hydrostatic, which is the pressure from water, and colloid osmotic pressure, which is water that is influenced by protein content. That's colloid osmotic pressure. Okay, and again, the functions of the lymphatic system are to conserve fluid and plasma proteins that leak out of the capillaries. They form a major part of the immune system that defend the body against disease and absorbs fluids from the intestinal tract. The lymph nodes are small oval clumps of lymphatic tissue located at intervals along the vessels. Okay. The superficial groups of nodes are accessible to inspection and palpation, giving clues to status of the lymphatic system. Okay, so remember we talked about earlier the right lymphatic duct, as you can see right here, drains into the right subclavian vein, and the left thoracic or the thoracic duct drains into the left subclavian artery, a vein, and that drains to the left side of the body. Okay, so that's what this picture is showing. The right lymphatic duct drains this side, and the thoracic duct drains this side. And once fluid, I just want to make note, once the fluid becomes a part of the lymphatic system, it's referred to as lymph. And lymph flow goes from the capillaries, like we said here, to larger and larger lymphatic vessels, where it eventually drains into the bloodstream by route of the subclavian vein, these veins, right and left. As it flows through the body, it passes through lymph nodes, which serve as filters to clean the lymph before it reaches the bloodstream. The lymph nodes are small structures that are located throughout the lymphatic system, and they contain cells called macrophages, which eat any pathogens or dead tissue or dead cells. The lymph nodes also have lymphocytes, and lymphocytes are T cells and B cells, which are involved in our immune response. They identify and make antibodies specific to a pathogen. The lymphatic system, which we're going to talk about next, also includes the thymus and the bone marrow, because these are the site of lymphocyte production. So lymphocytes are made in the thymus and the bone marrow, and it's here where they learn to recognize the self versus the non-self, right? And the non-self will be things like pathogens. Once they mature, or once they are able to differentiate and they learn the self versus the non-self, they leave the thymus and the bone marrow and they travel to the secondary lymphoid organs, the lymph nodes, the spleen, and the nodules, where they are able to encounter pathogens and become activated and fight off any disease. Okay, so the spleen is located in the left upper quadrant of the abdomen, and again, remember, it's the secondary lymphoid organ. Once the lymphocytes mature, they leave the thymus and the bone marrow, and they travel to the spleen, to the lymph nodes, and to the nodules, where they fight off these pathogens. The spleen, the function of the spleen, is to destroy old red blood cells, produce antibodies, store red blood cells, and filter microorganisms from blood. The tonsils are another structure associated with immune function. They're located at the entrance to the respiratory and GI tracts, and they respond to local inflammation. The thymus is the flat, pink gray gland located in the superior medial spine behind the sternum and in front of the aorta. Remember, the thymus is the location, the site of the lymphocyte production. Okay, so this is just a picture that shows the different sites of the immune-related organs. Thymus is here, spleen located in the right upper quadrant, lymphoid tissues in the intestines, and the bone marrow, which is also the site of production of lymphocytes. Now, in infants and children and in pregnant women, lymph nodes are relatively large in infants and children, and the superficial nodes are often palpable even when the child is healthy. With infection, excessive swelling and hyperplasia can occur. In pregnant women, hormonal changes can cause vasodilation and a resulting drop in blood pressure. A growing uterus obstructs drainage of the iliac veins and the inferior vena cava, which leads to deep-pented edema, varicosities in the legs and vulva, and hemorrhoids. Okay. So there's a couple more questions, and then that's it. Okay, so a nurse is assessing a femoral pulse. Where should the nurse palpate to feel this pulse? Yes, midway between the pubic bone and the anterior iliac crest. That's correct. Yeah. Which pulse would you palpate behind the knee? Popliteal. And how about on top of the foot? Does anybody know which pulse would you feel on top of the foot? Yes, Anna, yes. Dorsalis pedis, you would assess on the top of the foot. And how about the next one? Do you guys know just below the wrist on the side of the thumb? What pulse is that? Is that checking? Radial. Yep, correct. So the answer is the last one, and we just went through what these pulses are assessing. Behind the knee would be popliteal, on top of the foot would be dorsalis pedis, and on the side of the thumb below the wrist is the radial pulse. Good. And the thoracic duct of the lymphatic system drains into the blank side of the body. Do you guys remember? Left, yes, yes. The right side is the right lymphatic duct, drains the right side of the body. The thoracic duct drains the left side of the body. And it's important to remember the flows of the lymphatic drainage. Okay, so that's it for today, guys. Again, the next session will be next week from 10 to 12 again. Does anybody have any questions? Did it help a little bit? I know it's like so much information. I feel like I'm talking and it's really boring. I'll find out for you, Nicole. I have to find out from my supervisor. Okay, great. I'm glad. All right, guys. So next week, and we'll do the same thing with the questions afterwards from 10 to 12 next week. It's those other body systems that we talked about, the abdomen, GU, GI, and I think the rectum. Okay, so I'll see you guys next week. I hope that helped a little bit.